All right, we're going to switch gears back to biology and pathology, and let me give you Dr. John Sorkin from the University of Maryland.
So, ignore the man behind the podium. I'm going to speak to you a little bit less about healthy aging per se, but how we can get information that will help us determine, I'm going to speak to you less about healthy aging per se, but how we can get information about things that will help us maintain healthy aging. And in order to do that, I've got to get my slides, which is going to be fun. And specifically about things that are very hard to get information about. Okay, so let me start with, אני רוצה לדבר איתכם בעברית, לצערותו העברית שלי לא טוב, לכן אני אדבר באנגלית. For those of you whose native language is not Hebrew, let me translate and interpret. And for those of you whose language is Hebrew, let me translate in Hebrew, because my Hebrew is terrible. My mother and father would be pleased to know that I've been invited to speak in Israel, and I spoke in Hebrew. Abba v'ima kol tov. Okay, so hypoglycemia, mortality, and hospital readmission, the utility of big data. Healthy aging is usually cast in the terms of primary prevention, that is, avoiding the occurrence of disease. However, it often does not work, and we're stuck with what's called secondary prevention, that is, treating disease and keeping people with chronic diseases healthy. Diabetes is a common disease in older adults. In the United States, fully 25% of adults over age 65 have diabetes. In the year 2014, there were over 7 million hospital admissions where diabetes was either a primary diagnosis or a known medical condition at the time of admission. Secondary prevention of diabetes is generally along the lines of control of glucose concentration. We do that with oral medications, insulin, and lifestyle, that is weight loss and exercise. But we need to know what range of glucose concentrations we want to aim for if we want to have good secondary prevention. We do have some criteria that help us know what range of glucose concentrations to aim for. Greater than 126 milligrams per deciliter in a fasting glucose sample is diagnostic of diabetes. If your concentration is from 125 to 100 milligrams per deciliter, we say you have impaired fasting glucose. And if you're less than 100 milligrams per deciliter, we say you are normal. But I submit to you that these cut points are not complete. Why do I say that? We know that a glucose concentration less than 0, or in fact equal to 0, is not consistent with life. You will die. So how should we define hypoglycemia? Clearly, the cut point defining hypoglycemia needs to be less than 100 milligrams per deciliter, but how much less? This study will help you understand that. These data were analyzed specifically for this meeting. You are the first people to see it. 2.5 weeks ago when I heard about this, I ran to my office, started working on this, and didn't sleep until I got off the airplane. Okay, so why is it important to find hypoglycemia? Because hypoglycemia, both in hospital and out of hospital, may be related to increased mortality and increased readmission rate. So we need to know the glucose concentration that defines hypoglycemia and not allow people to go below that. So there are some additional cut points. 70 to 55 milligrams per deciliter has been defined in some circles as hypoglycemia and less than 54 as severe hypoglycemia. However, there is little empirical evidence to support these cut points. Why is there little empirical evidence? Because hypoglycemia is extremely difficult to study. Very low glucose concentrations are rare and are almost never seen in ambulatory healthy adults. I would bet you that if there are people in this room who are non-diabetic, none of you will get a glucose concentration that is very low. However, low glucose concentrations are seen in diabetics, but the problem with diabetics is when they get shaky, they eat something, They don't report what happened, but more importantly, there's no follow-up of what happens to them over time. So, how can we study hypoglycemia? One way is to use big data. This is the kind of work that's done by some of our colleagues at the University of Maryland, Baltimore County, the Champers Program, the Center for Hybrid Multi-Core Productivity Research. This was put in here to say thank you to Yelena, who is not here. Someone tell her I mentioned her study, please. Okay, so this study's admissions criteria, admissions to a Veterans Affairs hospital from January 2000 to 2014. The Veterans Affairs hospitals are hospitals specifically built to take care of people who served in the American military. We included in the study all admissions where the admission had associated with it an ICD-9 code for diabetes, or the admission was of someone who was taking anti-diabetic medication. This is just a way to identify people who are known diabetics. We also took people whose admission glucose concentration was less than 180 milligrams per deciliter. Diabetics will go much higher, but the goal of this part of the study was to study low glucose concentrations, not high, so we eliminated the high. But I'll get back to the high ones later on. All right, I said big data. We studied 835,192 inpatient admissions over that 14-year period. The average length of stay was, the median length of stay was 3.7 days. The interquartile range was 2 to 7 days. The average age of the admissions was 67.11 years. That's the mean plus or minus the standard deviation. All right, so how did we go about doing the mathematics? We did something called Poisson regression. The exposure was the lowest glucose concentration during the last 24 hours of hospitalization. The event rates were calculated within 17 glucose concentration categories, 10 to 19 milligrams, 20 to 29, all the way up to 170 to 179 milligrams per deciliters. For those of you who use rational units, I also give you millimoles per liter. 5 outcome measures were studied: 180-day, 90-day, and 30-day mortality, along with 30-day readmission rate to the hospital and 30-day readmission or mortality. This last is a composite of 2 others. All right. We used something called GEE to account for the serial autocorrelation of repeated admissions from the same patient. You don't have to care about that if you're not a statistician. If you are, you'll at least talk to me at the end of the day. You'll know I didn't do something really stupid. We calculated the event rates within the 17 glucose concentration categories, as I described before. The analyses were adjusted for a number of potential confounders. They are listed here. And then what we did is we said, we have these 17 event rates, but we want to smooth the rates to see whether we could define a hypoglycemic and normal glycemic region. So we converted the 17 event rates into 2 smooth regions. One, which we're going to call normal glucose, where the rate of bad outcomes is relatively unchanged, and another hypoglycemia, where the rate of bad outcome measure increases. We then identified the point where the 2 lines met, and that's called the knot. It's where the relationship between glucose and outcome changes. We did this by using something called a piecewise continuous regression, where we took the 17 glucose concentration categories and used nonlinear regressions with a pre-specified criteria that there would be a single knot. All right, these, you're going to see a number of figures like this, so let me go over it. On the x-axis, we have glucose concentration, minimum glucose concentration, the last day of admission. On the y-axis, event rate. Event rates get higher as you go up. This figure is for 180 days mortality. And you see at the line that we can separate between one region, that's the normal glucose region, and another region, because there's little change in the event rates, and below this region, events rates increase importantly. So we've got the normal glucose range, we've got what we're going to call our putative hypoglycemic range, and we've got the place where the 2 lines meet. We're going to call that the knot. All right, so for 180-day mortality, we see that there is, in fact, a region above which rates increase. By the way, the black symbols reflect the individual 17 rates, and the blue is the smooth line that we get when we do the piecewise continuous regression. Okay, everybody understand that? Let's move on. This is 90-day mortality. It looks very similar. Once again, a putative normal glycemic region and a hypoglycemic region. This is 30-day mortality, which also looks similar. This is 30-day readmission. Here, there's a little bit of a decrease above the knot, but it turns out this is not statistically significantly different from 0. And this is the 30-day readmission or mortality. Again, the fact that this goes up is not statistically significant, but this certainly is. Okay, so on this slide, I have put the knots together, the points where the two lines come together. And you can do what you want to try to determine hypoglycemia. Essentially, you can say, I have 5 estimates of what's hypoglycemia. The first thing you can do is you can take the average. If you take the average of the 5 values, you get about 70 milligrams per deciliter. Or you could look at it more critically and say, look, 180-day mortality subsumes 90-day and 30-day mortality, so I'm only going to take the 180-day mortality. Furthermore, 30-day readmission is independent of 30-day mortality and 30-day readmission. It sort of is another independent measure. And if you take the average of these two pseudo-independent measures, you get about 83 milligrams per deciliter. Or if you wanted to, you could say, what is the highest value within this range? And then you're going to get 90 or 100 milligrams per deciliter. So 3 possible definitions for hypoglycemia. Okay, so let me give you a summary to this point. Hypoglycemia is related to mortality and readmission. Event rates are little changed below the knot, that is at higher glucose concentrations, but event rates increase below the knot with lower glucose concentrations. And you can define hypoglycemia taking the average of that second set of 2. I'd say about 70 milligrams per deciliter. You should not let your patient's glucose get below 70. Okay. This is an example of an analysis that can be done using big data. There were 800 some odd thousand admissions used in this. But there's another question we can ask, and that is, what does glucose variability do to mortality in hospital admission? And I call this the utility of even bigger data. So the first thing we had to decide is how to measure variability. And one way you can do it is called the coefficient of variation, the CV. The coefficient of variation is the standard deviation of some numbers divided by the mean of those numbers. The higher the CV, the greater the variability. Okay, for this analysis, we used all subjects, all admissions, where the glucose concentration was somewhere between 10 and 599 milligrams per deciliter. Other values were set to missing. We thought they could be possible measurement errors. And here we had really big data. We had 34 million admissions. Nobody's impressed by that? Come on, say, ooh. All right. Inclusion criteria were similar to the ones I showed you before. From January 2000 to December 2014, we used the ICD codes to identify diabetics. Again, we used Poisson regression. But here, we did not group people by glucose concentration categories, but by categories of the coefficient of variation. As I will show you. And the event rates were calculated within 10 coefficient of variation categories. Each category had about 1/10 of the total subjects, or the total admissions. And again, we studied the 5 outcome measures. We used GEE once again to account for the serial autocorrelation of repeated measurements from the same experimental unit. And what we got out of this was event rates by 10, within 10 CV categories, each category representing 1/10 of the subjects. I didn't have to smooth these, as I will show you. So the only other adjustment was for age and sex. And here is the result of the analysis of the coefficient of variation of the glucose against the mortality rate. And what do we see? As the coefficient of variation increases, the 180-day mortality rate increases in what is largely a linear manner. This is the same data for 90-day mortality, and the picture looks very much the same. This is 30-day mortality, again the same, and this is the 30-day readmission rate, again a linear association, and this is 30-day readmission or mortality. Okay, so a summary of this part of the analysis. There is a direct linear relationship between glucose variability and all 5 endpoints. As variability increases, event rates increase. All right, what does this mean clinically? This means that you want to keep the glucose concentration of people as stable as possible. All right, now we put the two analyses together and we ask, does adjusting for the variability, the coefficient of variation, change the association of minimum glucose to concentration? So, very similar to the initial analyses that I showed you, where I used Poisson regression and GE to account for the correlation of repeated measures, and did a study within glucose concentration categories by 10 milligrams per deciliter of glucose. And we adjusted for all the things I mentioned before, but additionally, we are now going to adjust for the coefficient of variation of the glucose concentrations, not just that single minimum concentration, but all the concentrations the patient had while they were in the hospital. And that's why I've got 34 million observations, because those 800 some odd patients who were in for several days and had their glucose measured many times gave me 34 million glucose concentrations. Okay. Once again, I'm going to convert the 17 event rates into 2 smooth regions, one of normal glucose, where the rate of bad outcomes is relatively unchanged, and another hypoglycemia, where the rate of bad outcomes increases as glucose concentration changes. And we'll identify the point, the knot, with a relationship between glucose and outcome changes. We're going to use the piecewise continuous regression to smooth the relationships. And here are some results. Once again, on the x-axis, this is minimum glucose concentration. This is event rate, where this analysis compared to the first is adjusted for the variability, for the CV. And what you see here is very similar to what I showed you when I first started. There appears to be a region of normal glucose and a region of hypoglycemia, where event rates increase very quickly as glucose changes. This is 90-day mortality. It looks the same. This is 30-day mortality adjusted for coefficient of variation. And in the interest of time, I won't give you the others, but they all look the same. So summary. After adjustment for glucose variability, the relationship between minimum glucose and event rates was little changed. We saw 2 distinct regions. One we're going to label hypoglycemia, and another normal glycemia. Minimum glucose concentration predicted events. In this analysis, low concentrations were associated with higher event rate. And also at the same time, the coefficient of variation predicted bad events. Higher variability was associated with higher event rates. As a statistician, I have to say that glucose concentration and coefficient of variation were significant independent predictors. That means knowing one doesn't give you all the information that you get if you know both. You get a better estimate if you use both the minimum and the variability. Okay, so if there are any physicians here, yay, okay. Your take-home message is, in hospitalized patients with diabetes, maintain non-varying glucose concentrations and keep them between about 100 to 70 milligrams per deciliter. All right, let me now get to my real message. The use of big data allowed the examination of a relationship between 17 glucose concentration deciles and outcome, to establish the shape of the relationship, where we showed that there was increasing risk below the knot and little increase in risk above the knot. It allowed for the establishment of evidence-based cut points separating normal glucose concentration from hypoglycemia, using 17 possible values for that cut point. And we came out with a value somewhere between 70 to 100 milligrams per deciliter. So this was done not in months, not in years, but in fact in 2 weeks. Okay? This could not have been done as a clinical trial in 2.5 weeks. So let me do some contrast with a clinical trial if you wanted to do this. You would select a single glucose concentration as the putative cut point separating normal from hypoglycemia. You would test the cut point, and how would you do that? You would enroll a very, very large cohort of patients, in fact, thousands, if not tens of thousands or hundreds of thousands. And you'd have to do this because low glucose concentration is relatively rare. And let me show you that. This is the distribution of glucose concentrations in the subjects that were included in this study. There are 10% of the observations that are below 70 milligrams per deciliter. 800,000 subjects, 10% is 80,000. But, as the statisticians in the room will know, what counts is not the number of subjects, it's the number of events. And in this 10%, there were about 10% event rate. So you go from 80,000 to 8,000, and that's getting small. So you'd have to enroll an enormous number of people in a clinical trial. I doubt this will ever be done. Okay, once you've enrolled your subjects, you design your intervention to keep the patient's glucose concentration above the cut point. You would randomize 2 groups, one to intervention group where they would not get the intervention, the intervention group would get the intervention, and a control group that would not get the intervention. You would follow both groups and compare the outcome, expensive and time-consuming. At the end of the study, what would you have? You'd have information on one single putative value. I did 17 in 2.5 weeks. And then you'd have to choose another cut point and redo the whole study. This would take years. All right. I have some other investigators that I'd like to acknowledge. Mira, I'd like to thank you for inviting me to Israel. I was glad I was finally able to get here. Toda rabah. All right.
So that was a very important demonstration. I apologize for taking the microphone. Sort of. That was a very important demonstration of the power that modern technology has given us to do astounding analyses that we never could have done before. And I think that was really very dramatic. Anybody dare ask him any questions? That was very, very good. Yeah.
A very quick question, John, and I may have missed it, but why did you initially choose the last day rather than the first day?
I was asked why we chose the last day, and we did that because in the course of a hospitalization, usually when people come in on the first day, they are sickest. Now, that's not always true, but certainly by the last day, they are most healthy. Their medication should be tuned as well as possible. They're ready to go home. They're eating normally and so on. So we thought the last day would give us a more conservative estimation of the relationship between hypoglycemia and outcome than would the first day. Please.
Can you yell?
If it was diabetes that caused a hospitalization or a different cause, wouldn't that make
So I'm being asked if we looked at the cause of the hospitalization, whether diabetes, being admitted specifically for diabetes, would make a difference or not. It might or it might not, I do not know. But I can tell you as a physician that when someone who comes into the hospital has diabetes, regardless of what their admitting diagnosis is, if you do not pay attention to their diabetes, you will get bitten, and bitten badly. All right? But it's an interesting question. It's something that could be examined.
All right. Let's thank Dr. Sorkin. That was really good.
Listen to this guy. He's really good.